So I'm going to do the first presentation, which just is an overview of women, substance use and intimate partner violence victimisation. So there's three of us speaking, and then at the end we'll pull together some key implications for services and open the floor for questions around what works or what experience people have of delivering. So before I start, I just wanted to give people the heads up that this presentation contains direct quotes of intimate partner violence and abuse, which some people may find distressing. So please do step away and look after yourself if you need to. There's also a number there for the Australian National Domestic Family and Sexual Violence Counselling Service. So there's help there if you do wish to speak to anyone. So probably no surprise to anyone, but quite often when you talk about intimate partner violence, people just concentrate on physical violence, but we're talking about much more than that. We're looking at psychological abuse, sexual violence, sexual coercion, economic abuse, using children against your partner, coercive control, stalking and harassment, and also digital violence. So, you know, being able to check where people are on their phone or social media, etc. And intimate partner violence can occur in all relationships, regardless of gender. But this morning or this afternoon, we'll be presenting about male perpetration towards women, as women are more likely to experience severe or injurious violence, sexual violence, and also to be killed by a partner than men are. And substance use is a risk factor for both using and experiencing abusive behaviour. And there's a great division over the importance and appropriateness of individual, situational, cultural and social factors in explaining intimate partner violence. And all of the risk factors for intimate partner violence are elevated among women who use substances. So adverse childhood experience, mental health, substance use, etc. And before we go on to talk about my own research, the relationship between intimate partner violence, victimisation and substance use is a consistent risk factor in the literature, and it's present for both men and women who experience intimate partner violence. And this meta-analysis, which is a sort of key paper from the field, even though it's now 7 years old, found that drug use was a significantly stronger correlate with victimisation compared with alcohol use, and problematic alcohol use, so abuse, dependence, drinking problems, were more significantly correlated than just consumption measures for intimate partner violence victimisation. And the effect size for the strength of the relationship between substance use and IPV victimisation was significantly higher for women than it was for men. If I move on to my own research, which began right back with and before my PhD, looking at comorbidity, so mental health and substance use and violence among women who were used alcohol and drugs. And this is just a sort of comparison slide that I often use. So 8% of women in the UK crime survey had experienced intimate partner violence in the past year, compared to work that we did in 2011 when I was working in Spain, which was 57% of women in substance use treatment services. So that's 7 times greater. And then if you go on to look at the work that we did in 5 European countries, 7 years later, it was 9 times higher than women in the general population for women who inject or who are injecting drugs. So there's definitely a much higher proportion, and women's consumption of substances may enhance the risk of experiencing abuse by their partners. And I'll talk about why some of those risks might be increased, as well as, having an elevated risk, an elevated prevalence of known risk factors. And substance use might act as a coping strategy for women who've faced abuse. And in those 2 studies that we did in Spain and in Europe, you can see the types of intimate partner violence that women had experienced. So it's not just one. For very few people, it's just one type of abuse. So women are experiencing multiple types of abuse in the past year. And we went on to look at what the risk factors were for experiencing intimate partner violence for women who were in treatment in substance use. And you can see that women who lived with a substance user were almost 4 times more likely or as likely to experience intimate partner violence. And that led me to start researching men who abuse, but who also use substances, and try to look at solutions or behaviour change interventions for men. But you can see the other risk factors there around mental health and abuse in childhood. And then, as I say, we started looking at the role of substance use in intimate partner violence perpetration, and we had a 6-year grant looking at that. And we conducted a review of qualitative studies and interviews with men in substance use treatment, and then we separately interviewed their female current or ex-partners to really try and understand what role substance use did have in their relationships and in the violence that he was using. And here you can see the similarities and differences in their explanations of his intimate partner violence perpetration. So men tended to describe IPV as a one-off, arising from specific disputes or a perceived sexual betrayal, whereas women described a pattern of abusive behaviour and sexual jealousy. And women also described abuse linked to uncovering men's secret substance use or when men had relapsed to substance use. And men often describe their behaviour as, as protective. I was just trying to protect her, whereas partners described the same experience as controlling and overbearing. So it's important to sort of recognise these differences in any approach to supporting women. Sorry, I seem to have jumped on one. So one of the key questions we were looking at was what role does substance use play in IPV perpetration? And we found that men's substance use was linked with their use of abusive behaviour when intoxicated, craving, in withdrawal, and when acquiring substances. And in this slide, I've tried to so any quotes in purple are women, any quotes in green are from the men. So I've tried to pull out quotes that supported what men had said, but around these 3 key themes. So women said, once he consumes alcohol, he starts behaving like a dictator and fights with me for any small reason. And withdrawal and craving, this particular quote is from a partner who also used drugs. And she said, he made me responsible for getting the drugs daily, basically selling myself to get money. And there's other quotes where, he's jealous that she's sex trading, but he's making her sex trade. And then acquiring substances. So my son's father used to beat me when he didn't have money to get straight. He used to hit me when he was going through withdrawal when I didn't give him money. But substance use was rarely the only explanation for intimate partner violence. Men's abusive behaviour was linked with sexual jealousy and with their perceptions of women behaving improperly and opposing male authority. And sometimes, but importantly, not always, in the context of alcohol and drug use. So this woman says, things started getting physical. He just started getting really controlling. If he didn't like what I did, he'd hit me. I think he'd been drinking the night before because he'd been on cocaine and he was so paranoid, saying that I'd been seeing other people, and he just started hitting me. And then this other quote says, he just started getting really controlling where I went and who I saw. And if he didn't like what I did, he would hit me. Sometimes I feel like I can't breathe. It's like I can't go out and he's following me and he's asking me where I am, what I'm doing. So you can see that the context might be substance use, but it is not the explanation for the abusive behaviour. And women were subjected to a lot of economic abuse, which also put them in a difficult situation if they were going to be supported to leave. And so violence occurred when women refused or failed to raise money for drugs, or when men had used scarce family resources and diverted those to buy substances. So, the drug taking got worse and worse. So he wanted to sell something that I had to buy drugs. I tried to stop him. He punched me. One day we were out and I didn't want to shoplift anymore, and he forced me and dragged me off the streets, which meant I had to shoplift. I used to think, why should I shoplift, get money, and then you take my money and spend it on your friends? And then this is linked to the quote I said earlier on. So that woman's partner said, I don't like her doing it, sex trading, and that's the way she can get our money for drugs unless I pay for it for her. I'm a jealous bloke. She wanted to go out, make money and everything, and that I wouldn't let her, and she hit me around the head. I hit her back. Seem to have. Yeah, okay. And then just briefly to finish off, the impact of intimate partner violence on women who use substances, and that was alluded to in the introduction that was given. Intimate partner violence negatively impacts on women's health, mental health, physical health, well-being, and also outcomes. And in substance use treatment, and this is taken from a review that you can have a look at, substance use or intimate partner violence predicts substance use, sexual injecting risk behaviours. It can impede substance use treatment engagement and completion. It can increase the likelihood of relapse. It can also increase the likelihood of women becoming homeless or being in a situation where they have to sex trade, but it also increases the likelihood of child protection. And we used linked data to look at women in substance use treatment who were involved in the care proceedings. And again, women with a lifetime history of domestic violence were 5 times higher to have their children to be involved in care proceedings with their children. And again, you can read the report there. And so that's the sort of overview that I'm going to do. And if you want to read more about our research, you can have a look at our website, reduceipv.co.uk. And I'll stop now and pass on to the next person.
Thanks so much, Gail. Now I would like to introduce our second presenter, Samantha Colledge-Frisby. Sam is a research fellow at the National Drug Research Institute, also based in Melbourne. Her PhD thesis and current work is expanding our understanding of the harms that contribute to morbidity among people who inject drugs. Thanks. Over to you, Sam.
Thanks, Shelley. You can hear me? Thumbs up, Gail? I can see. Yeah, awesome. Thank you so much, Shelley. And thanks, Gail. That was a really interesting, confronting background into partner violence. And it's really an honour to be presenting today on such an important topic. I'm going to be bringing it home with some findings from our cohort of women who inject drugs in Melbourne and their reported experiences of gender-based violence. So just for some local context, the National Plan to End Violence Against Women and Children was released in October 2022, and in that was a call to identify and support individuals who are at high risk of experiencing violence, and also the provision of services to support and address existing violence. So further to this, the Albanese government labelled domestic violence as a national crisis in May of last year. So there's some clear political motivation to address this enormous issue. However, while international evidence, including Gail's, suggests that experiences of violence are incredibly high among women who use drugs and those who inject drugs, this group isn't identified in the national plan as a key population for whom resources and funding is being prioritised. And women can also be, and commonly are, excluded from health and social services due to their drug use, including violence services. So what we wanted to do was look at all the data that we had available and provide evidence to inform these discussions around reducing violence among women in Australia. Broadly, we wanted to estimate the prevalence of gender-based violence among women who inject drugs in Melbourne and compare this to the general population. We wanted to look at the proportion of women who reported accessing medical care and examine some characteristics associated with accessing this help. And we also wanted to include some information sourced from qualitative interviews about women's experiences accessing services for gender-based violence. So I'll just flag these qualitative interviews are about accessing health services more broadly as part of a focused project on sexual and reproductive health funded by the Jean Hales Foundation. But the rest of the data was from the Supermix studies. So this is an ongoing community cohort of people who inject drugs in Melbourne that's been running annually since 2008. If you've ever seen me present, you'll have heard of this cohort. Participants are asked a battery of questions relating to their drug use, health and social circumstances, including their experiences of assault. So I'll just obviously point out the key difference here. We ask about assault as opposed to the broad range of violence that Gail specified in her presentation. So in addition to these annual surveys, we also have participants' information linked to statewide records from hospitals, emergency departments and ambulance services, as well as the National Death Index and the MBS and PBS. So to investigate violence among women who inject drugs, we did use these data sources as well as the 11 qualitative interviews that I mentioned as part of the Jean Hales Foundation. So because we were interested in gender-based violence against women, participants were excluded from the Supermix cohort if they self-reported their gender identity as male, non-binary or other. Sorry, not from the cohort, just from this study. And we're mainly interested in participants' experience of any assault, but also looked at sexual and physical assault separately. And we looked at this using the self-report data as well as the linked health record data. So some very important, I haven't got heaps of time to kind of articulate the full method, but it's just some important notes about the method to bear in mind as we go through the results. So first, the survey data asked about lifetime experience of assault at baseline, and then at follow-up asked about recent experience of assault, including who the perpetrator was and the type of assault experienced. But the medical record data is only available from 2008 when the study began. So we decided it would be a bit more prudent to include medical record history from either 2000 or 2008 or when the participant indicated that they had initiated injecting, whichever came later. So just sort of excluding time where the participant hadn't injected, but we did have their medical data. So while the baseline data are quite complete for this initial question of assault, descriptive and follow-up data is patchy due to people leaving the study or being lost to follow-up, but also sometimes due to the sensitivity of the questions. So especially where we ask about the perpetrator and types of assault, there is some missingness across those variables. And the qualitative data is included as a supplement to the quantitative data just to provide further information on this topic. But there were some differences in terminology. These weren't sort of thought of alongside each other at all. This qualitative package was sort of separate to the quantitative data, so they don't marry neatly, unfortunately. But we thought just because we have this information, it was incredibly important to share it. So moving on to the results. Of the 471 women who responded to the question, and again, there was very low missingness from women in the sample at baseline, when we looked across the data, self-report and administrative, 83.2% of women had evidence of experiencing assault and 38.4% had experienced sexual assault. Looking across the different data sources, 80% of women self-reported assault at any time. 46% of women reported assault at follow-up, so after they'd initiated in the study. There were 117 hospital admissions for assault among 17% of the women. There are 131 emergency department presentations among 20% of the women. And I will just flag with the emergency department presentation. So the ICD codes that we used for the hospital admissions weren't used for the ED presentations because assault isn't typically coded in ED. We included presentations where assault was suspected by the clinician. So there were also 108 ambulance callouts among 15% of women, and there were no deaths related to assault among women in the cohort. Of the women who self-reported assault, most reported being victimised by a partner. That was about 50%. Although more than 40% reported being assaulted by a stranger. And it's just worth noting that this was different to a dealer or another person who uses drugs. So these are mutually exclusive categories, but the participants indicated a single perpetrator. So a person wouldn't indicate that both a stranger and a dealer assaulted them. I have separated out ex-partner and casual sex partner just to show some nuance in the data that we have. But you can see that about a third of women reported being assaulted by their ex-partner. I would say these typically fall under intimate partners. But yeah, just kind of interesting to sort of see the high prevalence of ex-partners or people who are being perpetrated by ex-partners. When we asked about physical assault type, and I'll just highlight that these categories have been aggregated. Beating and strangling was the most common category reported among people who were assaulted. I don't want to lean too heavily on these data because, as you can see, there might be some subjectivity to how someone may interpret attacked without weapons and other forms of assault. But I just think it's important to note that quite a high proportion of women were attacked or threatened with weapons, so just over 40%. When we look at the general population, the Australian Bureau of Statistics Personal Safety Survey conducted in 2021 found that 30% of women had ever experienced physical assault when they were over the age of 15, and about 20% had ever experienced sexual assault. So most women reported being sexually assaulted by a man that they knew, and over half reported that this was at the hand of an intimate partner. Only 6% reported sexual assault at the hand of a male stranger. So this just highlights some of the differences between our cohort and the general population of women. So we were also interested in women's experience accessing medical health care after experiencing an assault. 41% reported accessing some healthcare, majority of whom reported seeking counselling or going to the emergency department. And among women who reported assault during a follow-up interview, when we compared those who reported seeking help to those who did not on a range of covariates, we found that the only factor associated with seeking healthcare was experiencing sexual assault. And you can see the difference there, 21.8% versus 8.6%. So the reason that we felt very compelled to include this qualitative data was because 8 of the 11 women described previous experiences of intimate partner violence, including some who had been in multiple intimate relationships with men who had been the perpetrators of violence towards them, and some who had been hospitalised as a result of the violence. Most women described challenges accessing services and supports for family violence, including some who chose not to seek any support due to those barriers. Something of a recurring theme for women when it came to accessing all types of services, and Gail pointed this out earlier, is the issue of fear of child protection service involvement. So I think it was 5 times as likely, women who experienced assault were 5 times as likely to have child protection service involvement. This is a very high risk group for child protection service involvement. Sarah says here that she was too scared to reach out for help, and that, well, quote, "we need somebody that doesn't go straight to child protection," because she believes she could have opened up about her experiences of domestic violence and gotten help that way if there was someone else to speak to. I also think it's relevant to note very quickly that women describe the relationships with their medical practitioners as protective. So in the case of the OAT prescriber, this particular interaction didn't result in referral to services necessarily, but it did result in the woman leaving their partner who was assaulting them. So there was a positive interaction with the OAT provider who kept on asking the woman about her experiences at home. And that was a bit of a catalyst for her seeking help. However, Jane discussed this interaction with her maternal child health nurse, who sensed that Jane needed help and effectively orchestrated her and her children's relocation and access with refuge services, saying, quote, "they made me feel so safe." So very quickly, some key points. This is clearly a key population for addressing violence against women in Australia. And these women also experience violence slightly differently to the general population, in that a large proportion of women report experiencing assault at the hands of a stranger. And this likely points to the increased risk environments that women who inject drugs are exposed to due to sourcing or using their drugs. So although reducing this prevalence takes a multifaceted systemic strategy, some harm reduction strategies that exist could alleviate some of the violence risk associated with drug use. And from this and from other research we've done investigating health access among people who inject drugs, there seems to be a real fear of child protection service involvement among mothers in our cohort. I'll quickly flag Jocelyn Chan's paper that highlights the prevalence of this in the Supermix cohort. So this paper highlights that while this may be appropriate for some families, we do really need to be focusing on supporting families to stay together where possible, especially as it acts as a barrier to help and healthcare seeking. Finally, the data were a little incomplete on help seeking after assault more broadly. And the question that was asked about seeking medical health care, this was included in the first version of the survey nearly 20 years ago. So while this wasn't a perfect variable, something that we were really committed to was using all of the data that we had available to us. We do ask women every year these questions that are incredibly invasive, incredibly sensitive, and there's an onus on us as the researchers who collect this data to defend the collection. And so presenting what they find on behalf of these women is very essential. So I hope you found this informative, and if you have any questions that relate to this project, I'm absolving myself from responsibility until I'm back from parental leave in November, but Shelley or Ash would be happy to receive your emails. Thank you so much.
Thanks so much, Sam. That was another great presentation. Now over to our final presenter, Jade Lane. Jade is based at the Burnett Institute. She's an anti-violence activist and transformative justice practitioner with extensive experience working alongside communities impacted by structural and systemic violence. For a decade, Jade has led innovative local and international programs in sexual and gender-based violence prevention and public health. But before we hear from Jade, I just want to let you know that she's actually unwell with COVID, but has kindly agreed to present despite this. So we are incredibly grateful that she's here with us, despite that she's not feeling great. And on top of that, Jade has also she's also having tech issues, which means the mic isn't working and that she'll be speaking into a phone. So Jade won't be actually around for the Q&As at the end, but if you have questions or comments, feel free to pop them in the question link anyway, and we can pass them on to Jade after the presentation. Thanks. Over to you, Jade.
Okay, can you hear me? Can someone just give me a thumbs up if you can hear me? Okay, great. Hi, everyone. This is definitely the weirdest way I've ever given a presentation. I'm so sorry, but I'm very happy to be here with you today. So I'm going to be sharing a little bit of background information and some very early findings from a domestic, family and sexual violence research project that's led by and for victim survivors with a history of drug use and criminalisation, of which I am one. So next slide, please. I acknowledge the sovereign custodians of the lands I'm coming from, the Wurundjeri, Woiwurrung and Boonwurrung people, and pay my respects to their elders, past and present. Next slide, please. So mainstream responses to DFSB in Australia are largely shaped by carceral feminism, which is a theory and a practice that relies on criminal legal responses to violence through policing, courts and prisons. But these responses often cause harm. So for women with a history of drug use and criminalisation, police involvement can lead to misidentification, criminal charges, loss of housing or children, and even an escalation in violence. Rather than providing protection, these responses also expose people to additional forms of state violence on top of the interpersonal violence that they're already experiencing. And this is through things like surveillance, recriminalisation, exclusion from vital services, and even incarceration. And despite more than a decade of national strategies, including the National Plan to End Violence Against Women and Children, rates of violence in Australia haven't significantly decreased. So evidently something isn't working. And yet the voices of those who are most impacted by these failures remain largely absent from DFSB research policy and practice. Next slide, please. So that's where this project comes in. So we're funded by Australia's National Research Organisation for Women's Safety under the Men Who Use Violence grant round. But what makes it unique is that it's led by victim survivors, and specifically those with a history of drug use and criminalisation, as I mentioned. And we've taken this approach to actively disrupt the epistemic oppression of criminalised women who use drugs. So epistemic oppression refers to the systematic exclusion or silencing of certain groups from shaping the knowledge and policies that directly impact their lives. And we're often excluded from these conversations about DFSB prevention and response because we tend to fall outside of mainstream ideas of who gets to be seen as a victim or what a good victim looks like. And particularly for women with a history of drug use and criminalisation, we're often framed as incapable of understanding our own needs or unfit to shape public dialogue. So here we are to ensure that our voices, our resilience and our wisdom are woven throughout this conversation. And this research project has two broad aims. So firstly, it's to understand the pathways into and out of using DFSB among criminalised men who use drugs, recognising that these pathways are likely different from the mainstream population, and then to co-create non-carceral, community-led responses to violence that genuinely reflect the needs and priorities of victim survivors with a history of drug use and criminalisation. Next slide, please. So we've grounded our work in transformative justice, which is a political framework that's been developed by Black, Indigenous, queer, disabled, criminalised and drug user communities to respond to harm without relying on state intervention. These communities are among the most impacted by violence and systemic oppression, while also being the most likely to be harmed when seeking help. And so in response, they've created a range of grassroots strategies and practices aimed at addressing harm without relying on institutions that have historically punished or abandoned us. And so transformative justice really encourages us to ask, how do we respond to violence in ways that don't cause more harm? Next slide, please. To start to try to answer this question, our research project uses participatory mixed methods design aimed at exploring how transformative justice can be applied to DFSB in the context of drug use and criminalisation. So we've conducted a scoping review of transformative justice responses to DFSB to just get a bit of a sense of what's out there. And we are currently interviewing both victim survivors and men who use violence. Both groups have a history of drug use and criminalisation, to understand their experiences, both of using or being harmed by violence, but also of their engagement with state-based responses. And soon we will start a series of co-design workshops to create community-led tools and strategies for responding to violence in non-carceral ways. And what's unique about these co-design workshops is that we're not just working with victim survivors and men who use violence separately, but we're actually bringing people together to start workshopping these challenges as a collective. Next slide, please. So our scoping review found that while transformative justice is increasingly discussed in community spaces, it's still largely absent from the academic research, and especially in Australia. Most of what we found comes from the US, and it rarely addresses DFSB in the context of drug use or criminalisation specifically. But in the grey literature, we found a wealth of survivor-led thinking about how to respond to violence in non-carceral ways. And we also found that transformative justice offers a long-term community-based approach that aims to address the root causes of violence instead of just responding to its aftermath. So it really is a very prevention-oriented framework. Some of the core principles of transformative justice include do no further harm. So responses must not create new harm through criminalisation or social exclusion. Survivor self-determination. So the person who is most harmed should be the person who decides what safety, justice and healing looks like for them, and that this shouldn't be imposed from the outside by sort of state or criminal legal processes. And then it's also very interested in root cause analysis. So looking beyond individual acts and individual pathologies to address conditions like poverty, colonisation and social fragmentation. And you'll see some of the others on the slide, but the main thread that kind of connects them all is this idea that safety and justice must be created collectively and not outsourced to the state. So that we can start to learn how to build the political, social and relational ecology required to truly stop violence before it starts. Next slide, please. And we're starting to see some of these themes, the same themes from our scoping review echoed in our interviews with criminalised victim survivors. So participants have consistently told us that police and legal system involvement didn't make them feel safer, it made things worse. Some were misidentified as the primary aggressor, and others described losing access to housing, children or support services after engaging with police. Several described intervention orders escalating the violence that they were experiencing, especially when they were issued without consent. And one woman said that it made her partner retaliate because it looked like she had reported him even though it had been brought by the police. And others described that IVO as just a piece of paper, so something that didn't actually stop the harm but increased their risk. When we asked participants what real safety looked and felt like to them, they said things like having people they could trust, especially peers or friends who'd been through something similar and would know not to escalate things. Support that meets their practical and survival needs, so things like housing, healthcare and harm reduction services that are non-conditional or non-coercive. Being believed and supported without fear of criminalisation or child removal, and responses to violence that are relational, flexible and grounded in the context of their everyday lives. And at the same time, many women struggle to imagine an alternative to calling the police. So this really highlights to us how carceral feminism has occupied much of the epistemic base around what's even seen as possible in DFSB prevention and response. Next slide, please. So this is still very early stage research, and our findings are continuing to emerge. But what we're hearing across both the literature and the interviews is that transformative justice holds real promise as a framework for meeting the safety needs of criminalised victim survivors and people who use drugs. It allows us to move beyond crisis response and punishment towards an approach for addressing violence that foregrounds social context, relational accountability and long-term structural change. And by centering those most impacted by violence, we don't just aim to critique what exists. Instead, we're hoping to create space for new ways of thinking about and responding to violence. So for us, the question is no longer just how do we reform the system that we currently have, but what do we want to build together in its place? Next slide. That's all from me. And thank you so much for putting up with this very odd presentation style.
Thanks so much, Jade. As I said, we really appreciate that you were able to present with a beautiful presentation. I'm going to hand over to you now, Emma.
Hi, everyone. Sorry, bear with me while I'm also doing some tech stuff here. So I'm just going to spotlight Gail and Sam. Okay,
Do you want me to put the final slide up?
Yeah, I'm just conscious that I think because of our tech issues, we only got a couple minutes left for the webinar. But thank you guys, all of you, for presenting. They were really great presentations. And Gail, I think I'll throw to you for the last couple minutes.
Yeah. Hopefully I get to the slides. Yeah. So I just wanted to very quickly finish with it's time to change the narrative and be careful about saying things like, why doesn't she just leave? And I think from Sam's presentation, I think you said something like 33% of women had been assaulted by their ex-partner. So I won't go through these figures from Australia, but you'll get the slides at the end about the, increased risk when people do leave. And we've pulled together a sort of final slide, and I've been adding to it as people have been speaking about what can substance use treatment services do to support women who experience, I've got IPV, but it should be any violence against women. So the sort of key points I've got from all the presentations is the need to include women's voices and experiences in anything that happens, but also the need for alcohol and drug services to improve identification of violence against women, but also to improve access to support and training for staff if they require it. So, the need for screening and assessment, protocols, training, structured referral pathways, but also thinking about drug and alcohol treatment, harm reduction and bloodborne virus services. How can they look at what they're providing and how to better support women or recognise some of the behaviours that might be connected to gender-based violence. We know that psychological therapies for women that have experienced intimate partner violence or gender-based violence do improve some mental health and well-being in the short term, but few trials in that Cochrane review included women who used alcohol or drugs. And we've heard across all three presentations that we need to think about how women with children or services aimed at improving family functioning better work across intimate partner violence with women who use substances. And that was kind of it, pulled together very quickly. Sorry.
No, thank you for that, Gail. Do you have anything to add, Sam, or all good?
Just that I want to sort of emphasize Jade's point of doing no further harm. Oh, wow, went a bit dark.
Yeah.
I found that really fascinating, and I even caught myself with the language that I used of sort of isolating the man as perpetrator and how that can be doing further harm, and how we can potentially sort of change our language and our thinking around individuals who use violence, as Jade used that term, and I think that's a really fantastic term to kind of use going forward for me. So yeah, I'm very committed to that, obviously, and I thought it was just a really fascinating presentation from Jade and offered really beautiful insight. So I just want to say thanks to Jade, and what a trooper when she had COVID.
Yeah.
All right, thank you guys. I will start wrapping it up. Just before we finish up, I want to say thank you to all of our wonderful presenters. Thank you everyone in the audience for bearing with us with our tech issues. Thank you, Shelley, as well for sharing at the start. And just lastly, before we go, I just wanted to flag that we have our next webinar coming up, and the topic will be young people and vaping. And that will be on the 30th of April. So you can follow through to the QR link there or email andrew@curtin.edu.au if you'd like to attend that webinar.